Good evening, everyone. Welcome to the webinar on how to make sense of breast cancer data from ESMO 2025. It gives me great pleasure to invite our program director, Dr. Amol Akhade, medical oncologist, Fortis Cancer Institute, Mumbai, India. Over to you, sir.
So I thank all my faculty and all the delegates who have joined. This is an academic activity where we will be discussing the breast cancer data from ESMO 2025. So first we'll talk about the early breast cancer data. So I welcome my first faculty, Dr. Sneha. She is medical director and consultant medical oncologist from Mittal Bhilai Hospital, Bhilai, India. So over to you, Dr. Sneha. You start sharing your screen and please start.
Hi, is my screen visible, sir?
Yes.
Yeah. Just start the slideshow.
Yes.
Yeah, it's visible. Good to go.
Good evening, everyone, and thank you, Amol sir, for having me here. Today, we'll be talking about the early breast cancer and the ESMO updates 2025 on the same. So, we'll be talking about these 5 trials: hormone positive breast cancer, the Monarchy and the Natalie trial. Just 1 second. I lost my screen.
Ma'am, your screen is visible, ma'am. You can just tap on the next button, ma'am.
I can't see my screen actually. Lost here.
Ma'am, we will unshare your screen, ma'am. Then you can share it again, ma'am.
Yes, please. Can I share?
Yes, ma'am. You can share it now, ma'am.
Yeah. So we'll be talking about, sorry for the technical glitch, we'll be talking about these 5 trials, 2 in the hormone positive, the Monarchy and the Natalie trial, in the triple negative, the Planet trial, in the HER2 positive, Destiny 05 and Destiny 11. So to begin with the first trial, the Monarchy trial, it's the primary overall survival results of the adjuvant abemaciclib plus endocrine therapy for hormone positive, HER2 negative, high-risk early breast cancer. In the previous results of this trial, 2 years of adjuvant abema plus endocrine therapy has significantly improved the IDFS over the endocrine therapy alone in this subgroup of patients and is now considered the standard of care. And in the previous all analysis, the abemaciclib benefit has been sustained with a favorable OS trend. So this is the primary OS analysis for the Monarchy trial at the median follow-up of about 76 months. So the trial design was hormone positive, HER2 negative, node positive, high risk EBC, divided into 2 cohorts based on the clinical pathological features or the high risk based on the Ki67. They were randomized 1:1 to abemaciclib plus endocrine therapy for 2 years or endocrine therapy, and in the follow-up period, the endocrine therapy could continue as per the requirement. So in this, the key endpoint, the key secondary endpoint was the overall survival, which we will be talking about, and at the absolute benefit of about 1.8%, 86.8 versus 85% at the end of 7 years, at the 84th month, and with the hazard ratio of 0.84 with a p-value of 0.02. But the number needed to treat was about 55. And in the IDFS, which we have already seen before, there has been a sustained benefit over the next 7 years. That is 6.5% absolute benefit at the 84th month. So abema plus ET reduced the risk of IDFS events by 26.6% compared to ET alone. And the number needed to treat here was 15.3. And there were major distant recurrences which have been prevented by abema with a difference of about 4.5%. Now, to conclude, at the primary OS analysis, 2 years of abema plus ET had statistically significant improvement in OS with a median follow-up of about 6.3 years, and the risk of death was reduced by 15.8%, with about 30% patients living in with metastatic disease, 30% fewer patients in the abema arm living with metastatic disease. There were no new safety signals, but the real question is how many patients received the abemaciclib on progression. So now the abemaciclib to conclude, the abemaciclib was the first CDK inhibitor to show a statistically significant improvement in OS for the...
Sorry, ma'am, to interrupt. Ma'am, your voice is very low, ma'am. Could you please...
Yes. Am I audible?
Ma'am, it's very low, ma'am.
Hello? Can you hear
Yes,
me?
ma'am. Yes, ma'am. But now it's quite better. But requesting to please little bit be louder, ma'am.
Right.
Yes,
So
ma'am.
abemaciclib is the first CDK4/6 inhibitor to achieve a statistically significant improvement in the OS for patients with hormone positive, HER2 negative, node positive, high risk early breast cancers. Now coming to the NATALEE 5-year outcomes, NATALEE trial has also been in the similar adjuvant setting for the high risk early breast cancer, hormone positive, HER2 negative. And in the primary analysis of the NATALEE trial, there was significant improvement in the IDFS versus the non-steroidal aromatase inhibitors alone. And there have been sustained improvements in all subsequent analyses that have been done. So by that, ribociclib in combination with AI was indicated as the adjuvant treatment. But this is the pre-specified 5-year analysis of the NATALEE trial, with all patients being off ribociclib treatment for about a median of 2 years and the median follow-up of 55.4 months. So this was a open label multi-center randomized phase 3 trial with adult patient of stage 2 and 3 high risk EBCs with either genomic high risk or anatomical high risk, with randomization to ribociclib plus aromatase inhibitors 1:1 versus aromatase inhibitors alone. Here the point is that ribociclib was 400 mg per meter square, 400 mg per day and not 600 mg. So in this, the IDFS in the ITT population at the end of 55.4 months was 85.5 in the ribo arm versus 81% in the aromatase inhibitors arm alone, with an absolute benefit of 4.5%. So number needed to treat here to prevent one event was about 23. And it was consistent across all subgroups. In all the pre-specified subgroups. And if we go by the nodal status, there was a significantly better improvement numerically in the node negative versus the node positive subgroup. So in the node negative arm, the absolute benefit was 5.7% at the end of 5 years versus 4.4 in the patients who were node positive. So in the OS, which is still maturing and it continues to give a favorable positive trends favoring ribociclib plus the aromatase inhibitors, the absolute difference was 1.6% for these patients who received ribociclib plus the aromatase inhibitors, and the number needed to treat and to prevent one death was about 63. So to conclude, ribociclib plus aromatase inhibitors had a 28% relative risk reduction in the risk of recurrence or death after a median of 2 years post ribociclib treatment. Sustained benefit is continued, and the OS data shows a trend towards improvement, but data is still immature. So at this 5-year follow-up of NATALEE trial, the ribociclib plus non-steroidal aromatase inhibitors continues to reduce the risk of recurrence beyond the 3-year treatment window, supporting its use as adjuvant therapy in patients with hormone positive HER2 negative EBCs with high risk of recurrence. Now the third trial, that is in the triple negative subgroup, low dose pembro in addition to neoadjuvant chemotherapy, which is a randomized trial from India. The major problem in India is that we have a higher population of triple negative breast cancers and the standard of care is NACT. Keynote 522 that showed pembro in addition to the chemotherapy improved pathological complete response, EFS and OS, but the access is limited. There is financial toxicity, and we have seen low dose of immunotherapy working in other conditions. So this was a trial with stage 2 and 3 TNBC with no access to pembro, and they received either dose-dense chemotherapy alone or chemotherapy plus 3 cycles of pembro, 50 mg every 6 weekly. The primary endpoint was pathological complete response. Now, in this, the baseline characteristics were well matched, but we need to consider that there were more high-risk patients, less than 50 years, perimenopausal, T3, T4, with 84% having nodal involvement, stage 3 disease, and HER2 absolutely negative. So in the ITT population, the PCR rate was 53.8 versus 40.5, with the pembro plus chemo arm versus chemotherapy alone, with an absolute benefit of 13.3 in these patients. So in the subgroup analysis, almost all subgroups had a benefit of adding pembro to chemotherapy. So low dose chemotherapy, low dose pembro increased the complete pathological response when added to dose dense chemotherapy in patients with stage 2, stage 3 triple negative breast cancer. And the absolute difference of
Ma'am,
PCR.
sorry to interrupt. Ma'am, only 4 minutes left, ma'am.
Yes.
Yes.
So absolute difference of 13.3, which is clinically meaningful as keynote 522 of 14.5. And pembro dose was less than 1/10 of the standard dose. So we could reassess the dose to improve access and decrease the financial toxicity. So now coming to the HER2 positive domain, we have two trials here. The interim analysis of Destiny 05 trial, which is TDXD versus TDM1 in patients with HER2 positive disease having residual disease after NACT. So Catherine trial showed that adding another adjuvant treatment other than trastuzumab could improve outcomes. But the only problem was TDM1 did not reduce CNS recurrences. So this trial was designed in such a way that we could see whether the TDXD could be brought to frontline setting. So Destiny 05 was a global multi-center randomized open label phase 3 trial with key eligibility criteria of residual invasive disease and high risk defined at presentation prior to NACT, that is inoperable EBC or operable with axillary node positive after NACT. They were randomized 1:1 to TDXD 5.4 mg per kg every 3 weekly for 14 cycles or TDM1 3.6 mg per kg every 3 weeks for 14 cycles. Now, the primary endpoint here at 3 years was TDXD at 92.4% versus 83.7% for IDFS, about absolute benefit of 8.7%, with a hazard ratio of 0.47 and a p-value of 0.001. So TDXD reduced the risk of invasive disease by 53% as compared to TDM1. So in the secondary endpoints, we had similar results, and OS is still maturing, but showing a favorable hazard ratio of 0.61. Overall safety summary, the main issue here was the patients had a lot of drug-related ILDs or pneumonitis, that is 10.8% versus 2.5 in the TDM1 arm. Although they were reversible and grade 1 or 2 majorly, but 2 patients had lost their life to ILD. So Destiny 05 demonstrated a statistically significant and clinically meaningful improvement in IDFS and DFS with TDXD versus TDM1 in a high-risk patient, and it was consistent across all subgroups. Major issue here is that we need to take care of the ILD. The IDFS benefit with was the hazard ratio of 0.47 with a p-value of less than 0.001. So here we could think of this as a new standard of care in the adjuvant setting. Now, the last trial, that is the Destiny Breast 11 trial, where it is neoadjuvant TDXD with THP or dose-dense AC followed by THP for early breast cancer. Now, pathologic complete response, PCR, is a prognostic factor for EFS and OS in HER2 positive EBC. With the existing, we have about 40 to 60% patients with PCR and lower in patients with hormone positive. And in this trial, we had a randomization to TDXD followed by THP, 4 cycles each, or dose dense AC followed THP, and or TDXD 8 cycles. But TDXD arm was closed early last year in March due to futility, and the rest of the patients were continued for further analysis. So in this, we see that there were about 73% patients who were hormone positive and node positive about 90% patients. So the primary endpoint, that was the PCR, was higher in the intention to treat population, about 67.3 in the TDXD THP arm versus 56.3 in the chemotherapy THP arm. And same is applicable to hormone positive and hormone negative, with more benefit of delta of 16.1 in hormone negative patients. So neoadjuvant TDXD and THP demonstrated statistically significant and clinically meaningful improvement in PCR versus the dose-dense AC and THP. And this improvement was observed both in HR positive and HR negative subgroup, with a trend towards EFS benefit. And here we need to look at the data for safety, where the toxicity was lesser in the TDXD THP arm as compared to the dose-dense THP arm. 37.8 versus 54.3% of patients having these drug interruptions. So to conclude, TDXD-THP showed the highest reported PCR rate in HER2-positive EBC, despite the high prevalence of hormone-positive disease and high-risk population. It had statistically significant and clinically meaningful improvement in the PCR rate with a delta of 11.2%, and it was independent of the hormone receptor status or the disease stage. And this early positive EFS positive trend is favoring TDXD-THP versus the dose-dense AC-THP arm. PCR rate was 67.3%. More than two-thirds of the patient in the TDXD-THP arm had a PCR. More so in hormone negative as compared to hormone positive, but despite that, average is about 67.3%. So Breast 11 Destiny supports the TDXD-THP as a more effective and less toxic neoadjuvant treatment compared to dose-dense AC-THP and may become a preferred regimen for patients with high-risk EBC. Thank you. Thank you for patient hearing, and we will be delving more into the details in the panel discussion.
So thank you, Dr. Sneha.
Thank
So thanks for this lucid talk. May I invite our second speaker, Dr. Suman. She is Additional Director of Medical Oncology, Fortis Memorial Research Institute at Gurgaon, India. And she'll be talking about what's new in metastatic breast cancer in ESMO 2025. Over to you, Suman.
Thank you so much, Amol, for having me. Good evening. I'll just share my screen. Okay, I hope you can see my screen.
Yes, we can see it, but start doing, yeah.
Yeah.
Can have a slide sharing.
Yeah, I've done a slide sharing. I hope it's coming.
Yeah, it is coming.
Yeah. Okay. Again, thank you so much, Amol, for having me in the midst of such esteemed faculty. I will need 17 minutes to go through with a couple of updates on what's new for metastatic breast cancer, the ESMO 2025, and these are the 5 trials that I will be going through. I will start off with the Destiny 09 trial, which is the trastuzumab deruxtecan, the TDXT with PER2, versus the THP standard of care in HER2 positive advanced and metastatic breast cancer. So we're going to look at the key subgroup of interest and the additional analysis. So we are already aware of the schema of this particular trial, but what we are going to look at is the stratification factors. How does the de novo, that is about 52% of the population, how do they fare versus the recurrent advanced and metastatic breast cancers? How does the hormone positive, which is about 54%, fare versus the hormone negative population? And how does the PIK3CA, that is about 31% of the population, how does it fare versus those who are negative in for the PIK3CA? So we know that the Destiny 09 interim analysis showed a PFS benefit of about 40.7 months versus 26.9 in the THP group. So we are looking at now the graphs of the PFS in the de novo setting. You can see that there is a clear benefit, and even in the recurrent setting as well. So it demonstrates a meaningful PFS benefit in both the subgroups. When they looked at the overall response rates and the duration of response, you can actually look at the curves. Look at the graphs. 16.5% is the CR rates in the de novo setting versus 13.7 in the recurrent setting. This is as opposed to 6.5 and 10.7 in the control arm. So clearly showing a benefit regardless of the prior treatment status. When you looked at the PFS in terms of hormone positive status or negative status, you can see both the subgroups showed a clear benefit, and it was regardless of the hormone status. Again, if you look at PIK3CA detected versus not detected, I think both the subgroups did clearly well. So in a nutshell, PFS2 by subgrouping, it is showing a clinical meaningful benefit in all the subgroups across. What really needs to be discussed is how long, what is the optimum duration of TDXT, what is the implications of a prolongation of chemo-induced toxicity, what is the ideal maintenance strategy, who should get this, what are the risk factors and baseline biomarkers, and what is the incidence of brain mets with this. But in a nutshell, a median of about 3 years of duration of response consistently favoring the TDXT plus pertuzumab group, and this is definitely going to be the first line regardless in all the subgroups. So moving on to the triple negative breast cancer, and we are going to discuss two trials, the SN03 and the Tropion Breast 02. This is an unmet need because you know that 60 to 70% almost of the population of metastatic triple negative breast cancer are not eligible for any kind of immunotherapy due to the PD-L1 status. So we've got three different drugs: the TROP2-directed ADC, the saxatusumab govitecan, dato-DXd, saxatusumab tirumotecan. They differ in terms of their payload, their half-life, and hence their dosing as well. We are going to look at the XN03, the Tropion Breast 02. Uh, the XN03 looked at previous untreated, locally advanced, inoperable, metastatic triple negative breast cancer here who were clearly ineligible for the immunotherapies, and they had at least more than or equal to 6 months since the treatment in the curative setting. Saxatusumab govitecan was given at 10 mg per kg IV day 1 and day 8 on a 21-day cycle. And the treatment of the physician choice was a doublet, gemcitabine carboplatin, or Pacli or Napacli. So this was a little different in the Tropion Breast 02 trial, where they did include previously untreated, locally recurrent, inoperable, or metastatic triple negative breast cancer ineligible for immunotherapy. However, they looked at an interval from at 0 to almost equal to less than 12 months. So they took even those early progressive diseases. And here the chemo doublet, they did not have any chemo doublet. They were all single drugs. It could be Pacli, Napacli, Cabo, capecitabine, or eribulin here. There was a slight increase in the Asian population in the Tropion Breast 02 trial. And like I said, about 15% of the population in Tropion 02 was in the recurrent 0 to 6 months from the time of recurrence. This was different. And you can see there's no representation in XN03. No doublet in the Tropion Breast 02, but you see about 45% had a doublet. Taxanes were the highest used in both the arms, 55% in XN03 and 82% in a Tropion Breast 0 in the Tropion trial. Now, clearly, you can see there is a PFS benefit with both the in both the trials. 9.7 months the PFS in the XN03 versus 6.9 in the control arm, with a delta of about 2.8. The 12-month PFS being 41% versus 24%, and a hazard ratio of 0.62. Compare it with the Tropion Breast 02, hazard ratio for 0.57, PFS of 10.8 versus 5.6, and you can see the 12-month PFS is 46 months versus 26 months. Now, this is interesting that the comparator arm is about 5.6 here, which is very similar to KN355, 5.7 months, but you can see it is higher here at 6.9. Overall survival had not yet matured, but there was a PFS2 benefit in XN03. If you look at the response to the top two ADCs in the first line, you can see that XN03 was at 48% for saxatusumab govitecan versus the 46% in the physician choice. Dato-DXd was higher at 63% versus 29%. So they underperformed. The control arm underperformed in Tropion Breast 02. One of the reasons given is the lack of probably the doublet chemotherapy, and probably the higher response rates were also related to the population being within about 0 to 6 months as well. Dato-DXd definitely showed a clear OS benefit, as you can see here. 12 months, at 12 months, the delta was 7.4. But as you move on from 12 to 18 months, you can see it's a higher delta of about 9.9 months between both the arms. The median OS being 23.7 versus 18.7. And these are amazing results, especially in the triple negative breast cancer. And when they looked at the subsequent ADC therapies, about 53% of them did receive SG in the SN03. Tropion Breast 02, about 30% received some sort of ADC in the form of SG or TDXT or a tirumotecan. I also want to mention the follow-up of XN03 was shorter at 12.2 months, and the Tropion had a 27.5-month follow-up, a much longer follow-up. Now, we know that saxatusumab govitecan has side effects in terms of neutropenia, anemia, nausea, diarrhea. The dato-DXd, again, it's given once in 3 weekly, has a slightly different toxicity profile in form of oral mucositis, ocular toxicities, and we know ILD is a class effect. But if you look at the deaths, there were 2% deaths in the XN03, and this was related to the neutropenia with no primary GCSF prophylaxis being given. So, in the conclusions of these trials were that in XN03, there was a 38% reduction in the risk of progression or death, 4.2 months longer PFS2, and this definitely supports it as a new standard of care for patients who are not eligible for PDL1. Now, Tropion Breast 02 had both the the endpoints met, OS and PFS, and it was more than or equal to 5 months of improvement in both the arms. The safety profile was manageable, and the Tropion Breast 02 is actually representative of the real world in term, which is that 15% of population between having a DFI of 0 to 6 months. This is what we really see, and this is what is usually excluded from clinical trials. And having a trial that says that there is a benefit for this population is really very good for this population. Lastly, we come to the hormone positive HER negative group, where we have a newer drug, which is the gedatolisib plus fulvestrant, with or without palbociclib versus fulvestrant. And this is hormone positive HER negative PIK3CA wild type disease. This is the Victoria 1 trial, and this is, I think, an unmet need, because we know that a lot of trials do not address PIK3CA wild type population. Now, geratolisib is actually a highly potent multi-target PAM inhibitor, that is a PIK3CA, AKT, and an mTOR inhibitor, and this is given along. This is given in combination with the palbociclib and fulvestrant as a triplet arm, and geratolisib along with fulvestrant as a doublet arm, and just single arm, that is a fulvestrant arm. So there are 3 arms in this study, and a 1:1:1 randomization. Just want to point out that gedatolisib is actually an IV formulation, 180 mg IV, given once weekly, 3 weeks on, 1 week off. The population was progression on or after CDK4 inhibitors with non-steroidal AIs. At least less than or equal to 2 lines of prior ET was allowed, and there was no usage of chemotherapy prior to this, no mTOR, no PIK3, and no AKT inhibitors. The primary endpoint was PFS. Most of the population here did receive a prior CDK4 inhibitor for at least 18 to 21 months. And you can see a clear benefit in the PIK3CA negative population, 9.3 months in the triplet arm. This is the triplet arm versus 2 months in the single arm, that is fulvestrant, and an adjusted hormone hazard ratio for about 0.24. And I think these are really exciting hazard ratios for this population. And you can see the curves are separating here somewhere around 1 month. Compare this with the doublet arm. The doublet arm is showing about 7.4 months of PFS versus 2 months, again in the fulvestrant. Here the curves separate a little beyond 1 month, somewhere around 2 months. And when they looked at all the key subgroups, you can see that whether it was a menopausal status, the presence of visceral status, the liver metastasis, prior lines of therapies, or time to treatment progression, all across the triplet did better. Same with the doublet. You can see everything is towards the left. But when they compare the triplet versus the doublet here, there were certain groups that actually benefited from the triplet. So presence of visceral metastasis, triplet did better. Time to progression less than 6 months, triplet did better. Palbociclib prior, triplet did better. But when they looked at the overall survival, I think both the doublet and the triplet did well. The triplet at 23.7 months of median overall survival versus 18.5 months in the single arm. Adjusted hazard ratio of about 0.69. Look at the doublet arm, not reached median OS versus 18.5 months, and adjusted hazard ratio of about 0.74. Also, it is important to note that 108 patients had a disease progression on fulvestrant. 63%, that is about, 58.3% crossed over to the triplet arm. Again, crossovers were allowed here, and 10.2% crossed over to the doublet arm. The toxicities of this drug are as expected to this class of drug: the stomatitis, neutropenia, rash, diarrhea, and hyperglycemia. But I'd like to point out that the diarrhea and hyperglycemia were lower than what we actually expect from this class of drugs.
I'm sorry to
So
interrupt, ma'am. Ma'am, only 1 minute left for me.
I'll need 2 to 3 more minutes.
Okay.
Gedatolisib plus fulvestrant with or without palbociclib represents a potential new standard of care, and this is for especially for a PIK3CA wild type who has progressed on or after treatment with CDK4 by 6 inhibitor, and definitely this is an unmet need. This is the last trial, giredestrant with everolimus combination in ER positive, HER negative ABC, again, who has received and progressed on a prior CDK4 by 6 inhibitor, the EVA-ERA BC trial. Giredestrant is a next generation oral SERD, and it's a full ER antagonist and a degrader, and this is combined with everolimus, which goes and inhibits the PIK3CA, AKT, and mTOR pathway. So basically, we are covering all the resistant mechanism pathways that we know of. Here, the ESR, the patients were stratified based on the ESR mutation, and giredestrant is a 30 mg oral tablet given along with everolimus. The control arm was a standard of care, which is exemestane, fulvestrant, and tamoxifen, but most of them actually received exemestane. The primary endpoint was PFS. 55% had an ESR mutation, 35% had a PIK3CA mutation, 47% of the patients had a prior fulvestrant therapy. All the 100% had a prior CDK4 by 6 inhibitor. So you can see clearly there is a PFS benefit here at 9.99 months versus standard of care of 5.45, and again impressive hazard ratios of about 0.38, 62% reduction in the risk of progression or death, early separation of curves. Again, stratification in the and this is the ESR mutant population. I forgot to mention that. The benefit was there in both the ESR1 mutant population and the intention to treat population. The overall survival, again, benefiting in both the subgroups. This is what I wanted to show, the overall response and the duration of response. You can see that it is clearly higher in the giredestrant everolimus group in all the subgroups, the ESR mutant, ITT, and without ESR1 mutation detection. The side effects are more or less related to everolimus. There were no new safety signals because of giredestrant. So there is a significant improvement, and this is a new effective all oral treatment option, especially in the post CDK4 by 6 inhibiting setting. So I think we have a plethora of options. This is what we're trying to target, the PD in the 6 months. I think that is what we're trying to do by combining different pathways. We have to really look into whether doublet or triplet combinations, who deserves what. And we've got a lot of options now to choose from. And I think Amol will take us through the panel discussion to discuss all of this. And thank you so much for having me here.
So thanks, Suman, for this excellent talk. And now we'll move on to the panel discussion. And let me share my screen. I think, yeah, can I share my screen? Yes, are my slides visible?
Yes, sir.
And let me get into the slideshow. Is it full screen? Yeah.
Yes, sir.
So let me thank all my faculties, Dr. Paolo, Dr. Sergio, Dr. Sahoo, Dr. Atul, Batra, and Dr. Elisa. Thanks for taking time out from the busy schedule. I have no conflict of interest. Aim of the discussion is to make sense of breast cancer data for clinical use on Monday morning in clinics, because we are all practicing oncologists. And to begin with, we appreciate all the hard work that goes into clinical trials, and we thank all the patients who participated in those trials. So to start with, these are the trials we'll be discussing. So let us see, the adjuvant CDK inhibitors have definitely IDFS benefit. And if you see both the trials, Natalie and Monarchy, the magnitude of the benefit starts shrinking as the years go, but there is a significant amount of benefit, no doubt about that. There is an OS benefit also for Monarchy, and it is 1.8%. It is small, but definitely there is a survival benefit. We all know that for ER positive early breast cancers, showing survival benefit becomes difficult. Some of us must be knowing that still now there is no OS benefit between tamoxifen versus AI, technically speaking. So yes, 1.8 is small number, but it is significant. So let me start with Dr. Elisa. For patient who is high risk, node positive, eligible for both adjuvant abemaciclib and ribociclib, what will you prefer to use and why? Dr. Elisa, are you
Hi.
there?
Hi
Hi.
again, and thanks again for having me here. So, well, concerning this first question, for patients who are high risk, node positive, and eligible for both, I tend to prefer abemaciclib because we have more mature data, we have longer follow-up, and we now have the overall survival data that you nicely presented. Of course, these in absence of contraindication to these CDK4/6 inhibitors. So the first evaluation is whether the patient has or not contraindication to one of the CDK4/6 inhibitors. So then the choice is towards the one to which the patient has no contraindication. But in case of absence of contraindication or no comorbidities that hamper the use of one of the advanced CDK4/6 inhibitors, when the patient is eligible for both, we tend to prefer abemaciclib due to the longer follow-up, the more solid data, and as you presented, the overall survival benefit that we don't have yet, at least for ribociclib.
So absolutely right. Most of us prefer abemaciclib because it has a longer data and it is for shorter duration. But if you start on abemaciclib and some of our patients are not able to tolerate even at a lesser dose, do you switch to ribociclib? Are they interchangeable?
This is a very interesting question, and I think that a lot depends also on the regulation and reimbursement rules that exist for each country. So whether you have the possibility actually to give a CDK4/6 inhibitor after a CDK4/6 inhibitors in the adjuvant setting. So for my experience, I haven't had yet any patient who was not able to tolerate adjuvant abemaciclib also at the smaller dose, at the smallest dose of the 50 milligram twice daily. So I haven't find myself in this situation yet, but I think that if this was the case and if this was possible for the regulatory and reimbursement rules in my institution and in my country, I would do that.
Any other faculty wants to comment on this? Is it possible that patient is not tolerating abemaciclib? Can you switch over to ribociclib on adjuvant therapy? Anyone else has any thoughts?
Also, what's your experience in India? Can you do that?
Technically, of course, we are not permitted to do that, and that is exactly why I'm asking what you do in clinical practice, because sometimes abemaciclib becomes difficult to tolerate even at a lesser dose. So that is why we are asking the opinions.
I
Well,
will
in
bring
my
you feedback from America, from the US, where basically everything is possible if the insurance approves it, and they often approve it. So we do it sometimes. We switch from Abema to Ribo, and the trick there becomes for how long do you give it? If you gave already 1 year of Abema, should you give 2 more years of Ribo, or 1 or 1.5? And we usually make it up and try to reach the 3 years. But this is something that we do sometimes, because some patients start Abema at the full dose and just get hit by the GI side effects. And so they really say, I don't want to take anything anymore. And you're like, yeah, let's try Ribo. It has a very different toxicity profile. So we do it sometimes, and we usually try to reach the 3 years landmark.
Thank you. Thank you. So moving on,
Unfortunately,
now we have data about N0 patients expressed from NATLI, and it has shown significant IDFS benefit. So let me come to Dr. Sahoo. Will you use adjuvant ribociclib for node-negative high-risk patients? And if yes, how you define that in your clinical practice?
I think the Natalie inclusion criteria defines what they have spoken of as the high risk. The N0 is a tricky issue. All of us have questioned the data before, but gradually, as you see the data and you look into the world, real world scenarios, even from the Flatron and the real data sets which are coming in, it does come two things come out of it, that all N0s are not similar and you would like to risk categorize them. And if you look from a patient perspective, and if you look at the N0s as defined by Natalie as so-called the high risk, 20% would relapse at a period of around 15 to 20 years. And that is 1 out of 5 patients in a hormone positive, which you normally as a doctor would feel very comfortable. N0, HR positive, HER2 negative, they would relapse ultimately. So I feel there is a subset of patients, although if you look into the practice of N0, it will be only 10 to 12% of patients who fit into a Natalie high risk. But in India, the tricky issue is, I was going through the Indian data for any N0 with a grade 3 in Natalie becomes a high risk per se. The US is very different. They have around 10 to 15% who are high risk as per NATLI. In India, per se, because of the grade, you would have a much more higher cohort of patient, probably more than 50% who would fall into NATLI high risk. But yes, if I agree and believe the data, I would probably consider, and more so the mature data, 5-year IDFS from NATLI does start to show that the N0 and the N positives do have a similar hazards of risk of recurrence. So all this put together, I strongly believe we have to start to change our mindset about N0s, categorize them into the NATLI group as per high and not so high risk, and probably start offering them ribociclib.
Thank you. So now there is another interesting data. Does tumor biology change
Can I,
after adjuvant CDK4/6 inhibitors?
Atul has picked up his hand, and can I ask
Yeah, yeah.
someone, maybe from US, Dr. Paolo, what does he think of the N0 subset of Natalie? Maybe.
Yeah, Atul, please.
So if you go back to previous slide, Amol, am I audible? Yeah.
Yeah, yeah.
When you show the N0, if you look at the number of absolute events in both the arms that have happened, they're double digits.
Yeah.
Right. Can you speak out the numbers? I mean, it's 23 events and 38 events.
Yes.
And then we have 25 and
25 and
46
46.
events. So I think
25
we
and
should
46.
be a little careful when we say with so much this thing. The actual numbers, if you have to pick up this much difference, would require a much more number of events to say that with that surety. 5 or 10 events here and there, and all this can change. So I'll be a little more cautious. I mean, it's for sure it's showing something out there, but again, we need some more kind of follow up here for sure. More number of events. This is absolutely very low number of events at this stage of. I mean, if these are the numbers that we are looking at, the results are very, very fragile. They can shift either way
I
with the
agree,
number
Atul.
of
You have a point, definitely.
events happening here and there.
The data is maturing, and definitely we'll have to discuss this with the patient and let them make an informed decision. So moving on, there is an interesting data about does tumor biology change after adjuvant CDK4/6 inhibitors? And this is a paper recently published in ESMO Open. And then there are these questions that does exposure to adjuvant CDK4/6 inhibitors adversely impact metastatic biology? Does time from exposure to relapse matter? Will effects differ early versus late? And there is this recent paper published in ESMO Open, I think on September 9, and they have this classification based on relapse after adjuvant CDK4/6 inhibitor, CDK4/6 endocrine resistant, CDK4/6 sensitive but endocrine resistant, and CDK4/6 sensitive endocrine sensitive based upon the duration of relapse. And they have given a beautiful flowchart of what to do in each category. So this is some sort of not exactly guideline, but some kind of a statement that they have published in ESMO Open. So let me ask Dr. Paolo, what's your take on this? And of course, this particular paper of ESMO Open and this classification that they've shown. Dr. Paolo, your thoughts on this?
Thank you for highlighting it. And I was included in that paper because it's like a single institution experience from Dana-Farber, where we looked at just a few patients that had recurrence while on adjuvant CDKs. And we know that exposure to adjuvant CDKs does reshape biology in the metastatic setting. Single agent fulvestrant used to work acceptably and now doesn't work anymore because after CDKs, the tumor definitely is more aggressive. And now we're seeing it also after relapse in the adjuvant setting, with the caveat that these were the first recurrences that we saw. And so when you just collect the first 15 that recur, you're really collecting the worst actors, the most aggressive tumors. And so I don't think that this single study we published recapitulates what we're gonna see 5 years from now with patients that relapse on or after adjuvant CDKs. It recapitulates the early recurrences, and what we show is that those early recurrences have, in half of the cases, lose ER expression and have a lot of mutations in the p53 pathway and just are very aggressive tumor with short PFS. So I think in these cases, you really want to be more aggressive. And so I think thinking of cytotoxic treatment is worth, especially if they lost ER positivity, unless you have a very strong, actionable mutation where you can attempt something like, if you have PIK3CA, you can attempt something like the INAVO regimen, but it's clearly a tricky scenario. And just to complete, I don't know if I can speak of this algorithm, because I think we don't have data. We need to produce data in this important setting. We're going to see this situation more and more, and we need clinical trials, sponsored and ISTs.
So basically, the time will only answer as more and more patients take adjuvant CDK inhibitors and unfortunately have a progression. And then probably we'll have more data and maybe a real world data will tell us the answer. So let us wait for more data to come up. So moving on, we have a very interesting trial from India, and that's Planet trial, in which the Atul has used low-dose pembrolizumab in addition to neoadjuvant chemotherapy for early breast cancer, triple-negative patients. And of course, he has shown that there is an excellent response even with a low dose of pembrolizumab. And he has tried to show that low-dose pembro also works in an early triple-negative breast cancer. So, Dr. Sergio, what is your take? Do you think this data will be useful for you to tell your patients to convince about low-dose pembrolizumab when there is no access to full-dose pembrolizumab? And let me ask, how many percentage of patients from your clinic have access to full-dose pembrolizumab in general?
Okay, first of all, I want to congratulate Dr. Batra. This is a huge effort to present this clinical trial in ESMO. This is a big platform to say that and present those results. My interpretation about this clinical trial is a huge efficacy signal is consistent, and the Planet trial reproduced the 30% of absolute PCR gain magnitude consistent with the standard of care right now. And this trial have a few limitations. This is a phase 2 single trial and a small sample. And this result and hypothesis generating. And this is the first conversation that I in this case, this is the first conversation that I have with my patients, you know. Another issue with this trial is the different chemo backbone and the schedule, this dose dense ACT versus carbotaxane AC. And the another one is that we have to be careful with the low dose and not eliminate the risk of the serious immune-related adverse event. My clinical implication on my practical implication with this trial in LMICs like Latin America, the Planet trial support for the biggest randomized large trials of low dose of pembrolizumab powered for EFS, you know, ideally multicenter and including health economic endpoints. Until then, the standard dose of pembrolizumab is the standard of care in my practice. And my patients with reimbursement with the government coverage have 100% coverage of pembrolizumab in Colombia and in Mexico too. And for that, this is my standard of care in my daily practice.
Thank you. Thanks you, Sergio. But let us ask Pierre, Dr. Atul Batra, and first let him congratulate. Doing clinical trials, that too investigator-initiated in a country like India, are very difficult. So let me congratulate you on completing this trial and presenting it in ESMO. So let me ask you, are you happy with the results? And
Thank you,
anything that you could
Amol,
have
and
done
thank
differently?
you, Sergio. Yeah, I think results-wise, it's quite surprising that the absolute magnitude of benefit that we see in the terms of pathological complete response, I mean, they just match so similarly with the keynote 522. There are certain differences in the trial, but if you look at this was kind of a proof of concept thing that low dose pembrolizumab is definitely doing that, but to the pathological complete response. A lot of questions need to be answered. We don't know whether 50 mg is also a good low dose. Maybe even lower doses are working. We don't know what if we need 100 milligram. So this was based on 1 milligram per kg data that comes from lung cancer. and our average weight is around 50 milligram. 100 mg was split in 2 patients. So a lot of questions actually need to be answered. I think we're already seeing some questions by Dr. Sahoo that 1 carboplatin, 2, 1 year. So we don't know. One, if we get the result from optimized study that once we achieve a path complete response, we don't need to continue. I mean, then these 3 doses are good enough for patients who achieve a path complete response. We don't need to. I mean, the subgroup analysis does support that, but again, we don't have class 1 data to say that. Adding carboplatin was I think I've been asked this numerous times, but again, carboplatin practice is variable. We know that it has not adopted throughout by all. And when we were developing the protocol, this went on and on for quite a long time. And because of the variable practice, it's a small phase 2 trial. There was a lot of complications that could have occurred because of that. So we thought probably we'll just see what is the pure effect of adding low dose pembrolizumab. So that those questions have been discussed previously as well. And next step ideally would be, as clearly mentioned by Sergio, would be a multinational investigator-initiated study powered enough to look at the event-free survival. But I don't know who's going to fund that study. So this is what we have. And we have a patient who's sitting with you in the clinic where, of course, full dose is not an option. So this trial, the second inclusion criteria was patients who do not have access to the Keynote 522 regimen. So patients who have access to Keynote 522 are not eligible for this. Those are 95% of at least my patients. So how do we take this into the clinic? We, of course, discuss with the patients if this data is compelling enough. We have seen agents that have improved pathological complete response, but not shown the event-free survival. With just 154 patients, I don't know if we are going to get, I don't think we'll get enough differences in number of events, although these are very high-risk patients. We are following both the group of patients and will update within, I think, couple of years, most of the events would happen. So we'll see what happens with the number of events, but a lot of questions remain unanswered. But this mainly re-challenges, again, the dosing strategy for immune that has been done so many times, even by the Tata trial for head and neck, that they used 20 milligram, 1/10 of the dose.
Yes, I
So we
agree.
need to relook. It would require a global effort in countries where there is limited access to pembrolizumab.
Definitely. So thanks once again,
Yeah.
Dr. Atul, for this excellent trial, and we look forward for more data coming out. Moving forward, we have one more oral SERD, giredestrant, and he's compared giredestrant plus everolimus versus standard of care endocrine therapy versus everolimus. And yes, it had good results in intent to treat population and mixed population. But when you look at the ESR1 wild type, the data is not looking great. OS is still interim. So, Dr. Elisa, what's your take? If approved, will you use it for all comers or only for ESR1 mutated patients?
So first of all, let me say something that is not related to Evira, but I want to congratulate Dr. Batra for the Planet trial. I found that it was really one of the most interesting trials of this ESMO. And indeed, although these results are not practice changing for all countries where we have access to pembrolizumab, I think the study design was very brave and the results are very provocative and is the kind of trial that will never be supported by pharma. So it's really important to have this type of academic studies showing these results. Sorry for this interruption. And well, going into the Evira trial, yeah, I think that the Evira trial results are very interesting. I think it's a very likely possible new standard of care for the next future, so will likely be approved. I like the fact that in the control arm, they were using this combination of endocrine therapy plus everolimus. So that makes sense as a control arm to me, compared to, for instance, with the trial with the giredestrant, where the control arm was fulvestrant alone, that was a bit suboptimal as a control arm. Indeed, when you show these curves, to me, it kind of looks like the benefit is not seen in patients without ESR1 mutation. The benefit is really driven from patients with the ESR1 mutation. And also the benefit that we see in the intention to treat population is probably driven by the fact that the majority of these patients actually had an ESR1 mutation, like more than 50% had an ESR1 mutation. So to me, of course, I think that the population that really derives the benefit from these agents is patients with ESR1 mutation. Then in the end, it's probably also has an activity in those without an ESR1 mutation, but there is not really the added value of giving this agent to these patients when they could also benefit from another type of standard endocrine therapy that doesn't need to be necessarily this third. So I think that really the population that benefit is the patients with the ESR1 mutation. Then we will see what the authorities will approve for this.
Yeah. So looking forward to what approval it actually gets. Now moving on, we have new PIK3 CA inhibitor, and of course this trial Victoria 1 tried to show the benefit between triplet versus doublet. And if you see, of course, the triplet unfortunately has more toxicity, and there is of course, once you have such kind of trials, there is a cross-trial comparison that occurs. But if you see the results, and if you see the hazard ratio, 0.24, the PFS hazard ratio, it is probably unheard of in any of the trials. Maybe Destiny trial, some of the Destiny trials in, I think, some subset have 0.24 hazard ratio, but this is a quite impressive hazard ratio. But the trial has issues. So Dr. Batra, what's your take on this trial? How will you place these results? It's an IV drug, that too weekly IV, too much of stomatitis, triplet. Our patients want oral tablets. So what is your overall take on this trial, Dr. Batra?
Thank you, Amol, once again. This is the space where we, I think, need the maximum number of trials, and this is the space where we are learning how to treat such patients. Once a patient has progressed on CDK4/6 and has a reasonable first progression-free survival, we would be looking for an ESR1 mutation, a PIK3 pathway mutation, a PTEN loss, or BRCA1, 2, PALB2 kind of stuff, or if it's an early PIK3 wild type one, right? And this was the first part of the study that was presented. The mutated would be presented later. So this was for the wild type. So we don't know what proportion of these actually had ESR1 mutation. So according to your question about the control arm, they would probably, now we know that some kind of SERD would probably be the better control if we are taking all comers who are PIK3 negative, PIK3 wild type, right? Then it is again, if we look at now data from other PIK3 inhibitors or the same class of drugs, then this is an IV drug. If we remove palbociclib, then the PFS goes to around 7.3, 7.4 months, which again goes very similar to the prior drugs. They were lucky, fulvestrant didn't do well. Whether everolimus should have been added in the control arm is another question, or if there was an ESR1 mutation, they should have probably received some kind of SERD. Those are questions to be answered. But again, it's add to our armamentarium that we have one more agent with a different kind of toxicity profile with more mucositis rather than sugar issues. And I mean, just those same class of drugs, the data for the mutant would be more interesting if it's working this much in non-mutant subgroup. Let us see how it works in the mutant patients as well.
So thank you, Dr. Atul, for your opinion. So Dr. Paolo, now we have so many options, and let us assume that all of them get approved, and patient and the oncologist both are fortunate enough in a country where the access is not an issue. How will you use that? How does this EV-ERA trial compare to Serena-6, AMBER-3, Emerald? Which one will you prefer? So this is just a cross-trial comparison. I know it is a sin to draw a cross-trial comparison, but what's your take on this, Dr. Paolo? How will you choose?
So to make it brief, I could speak about this for 1 hour, but I think we don't have 1 hour, so let's make it brief. I think definitely combination treatment is becoming more appealing in the second line. And finally, we have oral third combination. The Evera regimen is extremely appealing. particularly for ESR1 positive patients for which there was a benefit. But in truth, you have to define what it means for the regimen to be effective. It was effective across the board, but it was more effective in ESR1 positive compared to fulvestrant. Fulvestrant is composed by an injection. Giredestrant is more convenient. So if we were in this ideal world where these drugs are cheap and where you can give them to any patient, I would give this combination irrespective of ESR1 mutation. But since they're highly costly, they may be approved only in ESR1 positive. I think this may become my go-to for patients with ESR1 positive tumors. That said, of course, the gedatolisib data, very interesting, good as a ratio, but I really don't like the idea that we're giving 3 drugs with different administration methods, IV, intramuscular, oral. It's a lot with side effects and with grade 5 events. So I think that will be more limited in its use. Are there still patients that can get single agent endocrine treatment like, I don't know, imlunestrant, elacestrant? I think those patients are becoming more rare, are just those patients that have been on first-line treatment for a very long time, but I think we're moving toward combos. What about Serena-6? Very complex because it's, it takes a lot of ctDNA testing. It's going to be a costly strategy overall, but the good thing about it is that it prevents the stark drop in the PFS curves. If you look at the PFS curves of Serena-6, they're more gentle in the way they progress. And so probably capturing progression early allows you to avoid early progressions. I think it is appealing, but I'm not sure if it's going to end up having really meaningful long-term advantages. So it will take time before we really implement that. What about first line? Will SERDs replace the first line? I think we will know by the end of the year, because at San Antonio, we may already see some data. I am among the skeptical, meaning that we have seen negative data with fulvestrant. We have to wait for the data before thinking of implementing SERDs there. There is a chance. And at that point, we really have to consider, having cost considerations and consider what to do in case of progression on a first-line oral SERD. So things are moving too fast, faster than we are able to do algorithms, but it's a good thing. And so I think we're going to learn how to use all these agents.
Thank you, Paolo. And we are looking forward to San Antonio and the data that you're talking about. So let us move on to the ADCs. ADCs face off. We have Ascent-03 versus Tropion-Breast-02. And the top 2 ADCs in first-line metastatic triple-negative breast cancer, which are not candidate for PD-L1 inhibitors. And we have 2 trials, 2 drugs, and both trials have differences. Of course, that was discussed in the talk by Dr. Suman. So again, coming to Dr. Paolo, you are the ADC man. Tell us which ADC to choose for triple-negative metastatic breast cancer, which is not eligible for IO.
So I think my colleague Dana-Farber Garrido-Castro had this wonderful discussion, put together all the points here on the left and the right. And if you just look at them, I think the answer is quite immediate. Because, on one side, you have an agent that doubled PFS, doubled response rate, significantly improved OS. It's given once every 3 weeks and had no treatment-related fatal adverse events. On the other side, you have an agent that improved PFS, but by a smaller degree, did not improve response rate, at grade 5 adverse events, and there was no improvement in OS. So right now, I think Dato-DXd seem to have an edge, is my preferred option in this case, acknowledging that there are some patients that may have some specific contraindications for which you may consider sacituzumab. But I think in this case, Dato-DXd clearly had stronger data, and it will become the go-to regimen for these patients.
Thank you, Paolo. So as I also agree that probably OS benefit is going to tilt the balance towards datopotamab deruxtecan. So moving on, going to Destiny-Breast09, and we all know that trastuzumab deruxtecan have wonderful results in first-line metastatic HER2-positive breast cancer in combination with pertuzumab. This data was, of course, presented in ASCO, and now we have subgroup analysis. And what they've shown is that almost across all subgroups, the combination works well. So now again comes a very key question. And again, we have plenty of drugs available. So Dr. Sergio, You said that you have no cost issue, everything get reimbursed. So what are you doing in your practice of metastatic HER2 positive patients in first line? Trastuzumab deruxtecan
Okay.
upfront, how long? Or you go with the standard THP followed by TDX1 on progression, or patina way? Where do you fit to tucatinib? So first
Okay,
Dr.
this
Sergio,
is
then Dr. Paolo. Your view,
this is
and any of the panelists can chip in because this is very important from clinical practice.
this is a tricky question right now because TDXD is a paradigm shifting, and this is practice changing in every way in neoadjuvant, in adjuvant, and metastatic breast cancer HER2 positive. And I think, like I said before, DB09 is a practice-changing study. TDXD and P show massive improvement in median PFS, 40.7 months over THP. This benefit is consistent around all subgroups, de novo recurrent, HR positive, PIK3CA, mutant and wild type. And I think if I have the opportunity in the future to have this first line setting, I choose TDXD in the first line setting. That is a sure, But right now my practice is the standard THP, like in all countries in Latin America. Even in Mexico, we don't have the opportunity to give for a patient TXD in the first line setting. TDXD upfront, how long? Stop and give HP. We don't have any data yet, but this is a clinical dilemma because DV09 protocol give TDXD until progression. And the question here is, all patients need TDXD for all the treatment way. I don't know yet, but the data that we have now, that is the support that give TDXD and P for all the treatment duration.
But do you think it will be feasible to give it for 2 years, 3 years? Is it possible to give the trastuzumab deruxtecan for so long?
I don't know yet because the ILD is a main concern for us. We have many patients with high comorbidities in Latin America, and I don't know, I don't feel comfortable giving TDXD for long time for these patients. I will be more comfortable use it like an induction treatment and maintenance treatment with the HP. And we have a few clinical trials running up, many in Europe, and we are so excited about that, the results in the future. I don't know what Paolo have to say because we don't have any treatment option apart THP in the first line setting.
So what's your thought, Dr. Paolo? What you will do, TDX1 upfront or any other way?
So once again, we're very lucky because we have many options coming together at the same time. This luck is giving us headaches because we don't know how to implement them together. But I think it's impossible to ignore how good the results of Patina were. They were just amazing. And this is why I think we have to keep it, at least in HR positive, HER2 positive, the maintenance with Palbo strategy. And then you can decide, if to give an induction with THP or TDXD pertuzumab. I think it doesn't make much difference because if you look at the DB09 curves, they start to separate after 4 to 5 months. Basically, when you drop the chemo, they really start to separate more. And so in truth, I feel giving a THP induction and then patina regimen is totally fine. If you have access to scalp cooling, you can keep the hair on, you have less ILD risk, but giving TDXD as an induction is also feasible. What about ER negative? And there, I think actually TXT may have more role even for a continued pattern. And then, it's not just forever or induction. You can think of giving it until tolerability is not optimal. And some patients, after 6 to 8 to 9 months, they start feeling more cumulative toxicity, more fatigue, etc. And at that point, maybe you can start dose reducing and dropping. So I think we're gonna go from a standard induction with taxane, 6 to 8 cycles, to a more dynamic induction, kind of discussing with the patients, figuring out how to dose reduce, and then stopping. And the problem is right now, we don't have great maintenance for ER negative. We only have HP, but tucatinib is coming. HER2 CLIMB-05, we know it's positive. I have a good feeling regarding the results of this trial. When tucatinib was combined with TDM1, I think was a bit disappointing, but here I believe it could shine and maybe prevent or delay some brain mets. And so the way I see it is probably we're gonna still retain some kind of induction, either with THP or TDXD. In ER-positive disease, use patina if it's available. We're doing that now. ER-negative disease, if the tucatinib data, HER2 CLIMB-05, are convincing enough, using tucatinib HP maintenance. And in this way, hopefully we're gonna keep patients on first line for years. And this will be really nice to see in the future.
Yes, let us look
Paolo,
forward to the Climb 05 data.
Sorry,
You want to
I
add something,
have a
Sergio?
question for Paolo. What is your daily practice right now with these clinical results in the clinical trials presented in ESMO for this
So yeah, like
patient?
for ER-positive disease, we kind of discussed within the group doing an induction either with THP or TDXT, and I personally favor THP, and then followed by patina. So basically doing what patina has done in ER-positive. In ER-negative, instead, using the DB09 regimen for most patients and trying to understand for which patients you can afford longer TDXT duration, for which ones instead you have to stop early. And I think that depends on two things: tolerability and response to a treatment. If you're having an amazing response, complete response, there is nothing left, maybe the patient had a good prognosis, no visceral metastasis, you can afford stopping earlier. But if instead you don't have an amazing response and the patient had high risk, maybe brain mets, you may want to give it for longer. And I have seen patients receiving TDXT for years and years. So many patients can receive it for years, and the risk of ILD is mostly high in the first year. If they go after the first year without ILD, the chance of an ILD is very low in the future. So I think some patients will get TDXT for very long. But I think for most patients, if they're having problems with tolerability of TDXT, or if they're having an amazing response, we can afford stopping it and use HP.
So thank you, Paolo, for this lucid explanation. Now moving on, we have two more trials, Destiny Breast 11 and Destiny Breast 05. They tried to get the TDXD1 in an early breast cancer setting, and both the results were presented and discussed, but there are some interesting issues. So Dr. Sahoo, let us understand, TDX1 alone failed. Are you surprised, or you think that because TDX1 alone has done wonders in metastatic setting, but in EBC, it seems to be not working alone. So are you surprised?
It was all about PATCR, and if I look into, I would expect that it was likely to fail because we are looking at a dual plus set chemotherapy here with versus a TDXT, which technically comes into a single targeted. So I would be interested in one arm, which would have been TDXT plus a PER2, if at all it was feasible, and then that would have made it probably a little more, because this is around that single agent. If you look into the data set of NSABPs and look into the single agent data set of trastuzumab plus a chemotherapy, it's around 40-45%, and that's where the TDXD arm is fixed at. So that is what it is all about. And if you look into the when we go into a dual HER2, it is coming to 60 to 80 depending upon the hormone, positive or negative. So that's exactly what's happening. So I think this was expected. If it would have been otherwise, I probably would have been surprised.
What about the control arm of the trial, the TCHP? Do you think that they should have taken TCHP? Would have been
carboplatin, I'm not pretty sure. I would not be using a lot of carboplatins at this point of time. I understand when the trial was designed, but today it would have been a taxane backbone with a dual That's probably my go-to regimen.
So you're not worried that there was no TCHP as a controller in
No,
DB?
I'm pretty happy because there has been enough data set, and at least in this ASCO, we have the NeoCarb, which really put it in the perspective. We also have the Helen. So we all know that carplatinum is not going to do much in the HER2 positive. So I'm pretty happy with taking away the carplatin. Toxicity will be much lesser. It's fine. I think that's the way to go forward.
And Dr. Elisa, do you agree with these issues with DB11, which has been highlighted?
That post-surgical treatment was not protocol mandated. A larger proportion of patients with residual disease did not receive TDM1. Unclear how many received endocrine therapy. Well, I think that this is actually something that is very common to many clinical trials, in the sense that especially lately in years, a lot of clinical trials open their sites in countries where there is no access to many drugs that are part of our standard of care as per our guidelines. So the question on how would the results have been if all patients would have received all treatments that are available as per standard of care in all the other settings except the treatment explored in the clinical trials is a thing. I think we do not have an answer for that. I think this also applies a little bit to Destiny Breast 09. If we look at the treatments that patients received in the early setting, we can see that there was a relatively very low proportion of patients that had access to the dual HER2 blockade, or patients that had access to trastuzumab even. So the question whether these results would have been the same if all patients that had access to the same treatments, all treatments that are indicated by our guidelines, it's an open question. So yeah, still, I think that the results of DB11 are very interesting, and those of DB05 even more. Between the two, if I may be honest, I prefer the approach of DB05, like the post-neoadjuvant approach, because it's a trial that really selected these very high-risk patients. So we know that these patients that were inoperable at diagnosis or with this residual disease in the lymph nodes at surgery are really patients with a high risk of relapse. So giving to this selected patient population TDXD in the post-neoadjuvant setting, I think it's really an interesting strategy. And still TDM1 can remain an option for all the others. But yeah.
Thank you. Thanks. So moving on, Dr. Sergio, do you think that DB05, there is a CNS protection effect, so that makes the case for TDXD used in DB05? Dr. Sergio, are you there?
Sorry, my microphone, sorry for that. And my interpretation about CNS protection in Destiny Breast 05, this is the strong signal positive and meaningful. We observe a numerical reduction of CNS result, 2.1 versus 3.1 in the TDM arm, that represent a reduction of 32% of CNS events as a first recurrence. This is clinically important because the historical limitation about TDM1 is the CNS protection, but I see with the results two limitations. One is the non-mandatory CNS imaging in those two trials. We don't know the real CNS metastasis at the first screening, and the most critical limitation is the lack of mandatory of CNS in imaging at the baseline during the follow-up. And the second one is the question that is not fully answered in those two trials. What the trend is encouraging, we cannot yet conclude that TDXD provide prophylactic CNS protection. The data is associated with a fewer CNS recurrence, which are very important distinction, but we don't not have the opportunity to say that TDXD provides a prophylactic CNS protection right now.
Thank you. Dr. Atul, you wanted to say something?
Yeah, I think we should also be looking at one is looking at the absolute number of events that are happening in the CNS, but another would be to look at the proportion of the total events that are in the CNS. So overall, you have to see that NR2 has reduced the overall number of recurrences as well.
Correct.
And so the number of CNS events would be less, right? Out of the total, how many are CNS? If you look at that ways, you would see that there is probably no difference.
Fine.
Right?
So that's
I mean, this is another way to look at it. That is, I think the CNS point is probably, this is also, I mean, just a view, nothing, I mean, the proportion would still be similar kind of thing.
Thank you. So moving on, Dr. Paolo, the DB05 is not powered for EFS. Are you disappointed? Such a big trial, they could have designed in such a way that it is sufficiently powered for EFS, or do you think that's okay?
I think here you mean DB11. DB11 was not powered for EFS. And I
DB11.
agree that it should have been. I don't think we should approve drugs, only based on PCR. I think in this case, they will get away with it because they have another trial, DB05, that was powered on EFS, and it showed that the drug is able to prevent recurrence. But the problem is it's a different population, so it is challenging. One key point that makes me like the DB11 regimen is that it's better tolerated than the control arm. Anthracyclines are tough. Anthracyclines have long-term side effects. Getting rid of anthracyclines, it's clearly a good thing. And 4 cycles of TDXD are not so bad. The rate of ILD is very low. It was lower in the TDXD arm than in the anthracyclines arm. So overall, I do like both strategies. I do feel that the DB05 strategy, adjuvant, is very selective. Very few patients are eligible for that. Only inoperable at baseline or node positive residual disease. There are still many patients with standard residual disease, node positive, that will receive adjuvant TDM1. And then the DB11 strategy, I would like to make it more dynamic. I like the idea of switching the regimen, starting with THP. And if the tumor is ER negative, HER2 positive, is responding amazingly, and there was not much burden at baseline, maybe you can get away just with THP. And after 4 to 6 cycles, you can do an MRI, and if you see no more disease, go to surgery. But if there is clearly residual disease, or if there is a lot of burden at baseline, you may want to give the whole DB11 regimen, THP and TDXD. So I think in the future, we're going to try to become more dynamic, to use a lot of THP, to drop the carbo, to drop anthracyclines. And I think it's going to be a good future because we're going to be able to give less to patients that may get less, and to give TDXD only to patients that really need it. And it seems like it's a very effective regimen.
Do you think the HER2-DX will help in this?
I think many things potentially will help. We have trials with the PET scan, we have trials with MRI, trials with ctDNA, trials with HER2-DX. I think, you couldn't think of using all of these or one of these. I just think we have to validate one of these and show how it helps. For the moment, the MRI strategy seems to be the most appealing to me because it really shows you if there is some residual disease. HER2-DX is very promising, but still, I think we have to figure out how to use it. We need a trial that shows us how to use it. PET scan also, it's interesting, but it's not clear. But overall, all of this could be helpful. For the moment, to me, the closer to prime time seems to be the MRI. And there was this TRAIN-3 trial that was interesting, showing that especially in ER-negative HER2-positive disease, the MRI works very well to figure out which patients are getting into PCR or not.
Dr. Sergio, you want to say something?
Yes. Do you think all the patients need this approach that TDXD sequentially with THP, even when we have the results about the MRI at the 4 cycles of chemotherapy plus HP are sufficient in patients with complete imaging response? Do you use this approach with this data in the TDXD sequentially with THP?
So I think we have to distinguish stage 2 from stage 3. Stage 3, we're talking of very high risk usually, and there you want to give more. And that more can be, depending on your practice, TCHP or with anthracyclines, or in the future with TDXD. I think you want to still give all the package to stage 3. But stage 2, which is the majority of the patients, at least that we see at Dana-Farber, is where you really can tailor. We know that about half of stage 2 patients can get to PCR just with THP for 4 cycles. Even more than half, 60% with 6 cycles can get to PCR. They don't need TDXD, they don't need anthracyclines, they don't need carboplatin. So the trick is finding those, and this is why we're talking of all of these biomarkers. So yeah, I think for about half of the patients, they may do well just with THP, just with paclitaxel, trastuzumab, pertuzumab for 4 to 6 cycles. Then you have the other half that we need to recognize, for which we really want to give more cycles, 4 cycles of TDXD or anthracyclines or something more. And that is going to be the major effort to do, but we are already doing it with MRI after 4 cycles.
So Dr. Atul, Dr. Sahoo, your takes on this? Do you want to go TDXD when in a neoadjuvant or an adjuvant way, if it is approved and available and accessible? Dr. Sahoo first.
Yeah, so for me, 11 is something which I feel at this point did not show that TDXD is the way to go forward, at least at this stage for in a new adjuvant setting. Still, that standard dual HER2 plus a taxane backbone should suffice. Stage 3, there is no clear-cut guideline that even anthra or carbo would help. We all believe it's a high risk. You want to add it, but not sure that how much it will add to. The main also problem is after you've exposed the patient to TDXD, doesn't achieve a PAT-CR, does TDM1 work? And we are not sure. And trials have probably not answered that, and that is the tricky part of the story. So, and for the other study of the TDXD versus TDM1 in the non-PAT-CR, which was there in the O5, I feel it makes sense to start discussing once the drug is approved in this setting for the new adjuvant. At least for me, no, that's a very clear cut. And after Atul completes, if he wants to add something, I can take the next one then.
Dr. Atul, final thoughts on this? We're running out of time.
So I would like to give a food for thought now, that in terms of when we are able to give an HER2 for residual disease, in high-risk patients, our EFS is reaching 92%, then we need to start relooking at PAT-CR as a surrogate marker, right? If PAT-CR patients used to do better, but now those who have residual disease in high-risk patients are able to reach to 92%. So if the DB5 arm, if the DB11 arm had in HER2 in the residual disease, then would it still matter that we have a PAT-CR or not? We would be treating more patients with HER2. So I would actually be more this thing in a kind of customized way of approach in the neoadjuvant setting, minimizing toxicity and starting with THP and then seeing the response, then see, even if we have residual disease for those high-risk patients, we are still getting to 92%. So DB11, I would really be cautious. There are so many things that are questionable in DB11. DB5, yes.
Fine. Dr. Elisa, your final thoughts, if you're there?
Yeah, I agree. I already said it before. I mean, I really like the approach of DB05, like the adjuvant setting, because to me, they really select a very high risk population where we know these patients are at very high risk of relapse. So there I can clearly see the benefit in the balance of giving TDXD, that we know it's also a drug that in the early setting can create some concerns for the risk of ILD. There were deaths in these trials, and we're talking about a population that is supposed to be cured after this treatment. So in DB05, so adjuvant setting, the patients that are selected there are really very high risk with these inoperable disease diagnosis or with this nodal disease at surgery after the neoadjuvant treatment. So there I can clearly see the benefit of giving an active agent like trastuzumab deruxtecan, and we have survival data. So once again, for DB11, we have PCR still. So yeah.
Yep.
That's my main take on this.
So most of us are trying to probably favor DB05. So thank you, everybody. We are already running out of the time. And I really appreciate and thank all my faculties, Dr. Paolo, and Dr. Elisa, Dr. Sergio, Dr. Atul, Dr. Tarini, and all the delegates who have joined. We are almost 170 odd delegates during our talk. So I thank you all, and I'm looking forward to such more interactive sessions with all of you, and I really appreciate it. Thanks for your time. Thank you. Thank you, and have a good morning, good afternoon, good night, wherever you are, in whichever corner of the world. Thanks for correcting. I really
Thank you for having us. Bye, everyone.
Thank you very much.
Ciao.
Bye,
Thank you.
everyone.
Thank you.
Good to see you all. Thank you.
Thanks. And I'll thank Kavina Creations for the wonderfully hosting this particular webinar. I really appreciate it, and I think it's time to say goodbye. See you. Take care. Bye.
Bye-bye.
See you.
Bye.
Bye-bye.
Bye.